The following podcast is part of a certified educational activity titled Hypertrophic Cardiomyopathy Care in the CMI Era, Elevating Outcomes with Cardiac Myosin Inhibitors. Access the entire activity and complete the post-test at peerview.com/MYA860. Downloadable slides and practice aids are also available.
Good evening, and thank you for joining us for this, what we think is an exciting session. Next hour or so planned for you. I am Milind Desai from the Cleveland Clinic, and with me is Dr. Anjali Owens from University of Pennsylvania. And the next hour or so, we are going to talk about what we seem to think we know about hypertrophic cardiomyopathy, all the new stuff that is happening. How do we take care of patients in the cardiac myosin inhibitor era, elevating outcomes with cardiac myosin inhibitor? So what do we plan to achieve? We need to recognize that early recognition and differentiating HCM from other things is crucial for optimizing outcomes. We will talk about guideline-based management of obstructive HCM, which now includes cardiac myosin inhibitors. We'll talk about data on CMIs, and basically we will approach real-world data as well as the concepts of shared decision-making. Again, I'm Milind Desai. Dr. Owens has told me to not make any mother-in-law jokes today. So I will not do that.
Not at all. Casino is free game, but no mother-in-law jokes.
Yes. Okay. I always do that. So obstructive versus non-obstructive HCM anatomy. How do we define HCM? It is more than 15 millimeters or more than 13 millimeters in family history individuals in association with the positive genetic test. This is something that has been in the folklore since 1973, as we have read the papers. But I think right in front of our eyes, the definition may be evolving. So be on the lookout, not just for new therapies, but for these kind of things, new definitions. The full spectrum could be normal, without obstruction, to all the way obstructive, apical, mid-cavitary, etc. And over the course of one's life, progression may occur from one phenotype to the other. This is an equal opportunity offender, okay? And it is certainly clinically underdiagnosed. The prevalence is about 1 in 500 to 1 in 200. Median age is 46. If this is a genetically inherited disease, and if the median age is 46, then at the very least, we need to do something to move the needle leftward. Underdiagnosis is 2 cases missed for every 1 diagnosed, and 700,000 folks in USA. If you take India and China, the other day I counted with 3 billion people there. That's a lot of people, 6 million people. So think about all these things, and there are disparities in terms of diagnosis as well as care. When should we suspect HCM? Exertional dyspnea, dizziness, syncope, chest discomfort, palpitations, etc., 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 right? All of this sounds like somebody with heart failure, somebody with angina, somebody with what have you. But if this is in the context of autosomal dominant inheritance, deaths, unexpected sudden cardiac deaths, heart failure, stroke, and the dynamic LVOT murmur in the setting of an abnormal ECG, all these things lead us to the promised land of a diagnosis. We've recently published at ESC on long-term outcomes in asymptomatic individuals. A lot of us are going to be dealing with these patients, right? In 3,000 plus patients, look at the median age. Mean age is 61 years. Over 10-year follow-up, about a quarter of these folks became symptomatic. And those who were obstructive had worse longer-term outcomes compared to non-obstructive. This is data from yesterday. Again, 1,299 patients who underwent stress echocardiography at the Cleveland Clinic, all asymptomatic. What we showed is non-obstructive HCM does better, but folks with obstructive HCM who do not undergo myectomy have worse outcomes. Patients who do not have appropriate exercise capacity on treadmill have worse outcomes. The other thing is about 22%, so 1 in 5 patients had latent LVOT obstruction. So just waving your hands on resting echo when they don't have a gradient is not enough. You got to work on it to elicit the gradient. That brings us to what is appropriate imaging, and the guidelines prescribe the following. Echo is the mainstay, first line. Okay, it helps characterize disease, LV outflow tract gradient, mitral valve, screening, as well as follow-up. Cardiac MRI does provide adjunctive value, including myocardial fibrosis. TEE is generally reserved for undiagnosed cases or for procedural planning. And nowadays, there's emerging role for scintigraphy because about 10% of HCM folks may have amyloid. AI, we are using AI in earnest to make the diagnosis of HCM on routine ECGs. And in one of the studies we did at the Cleveland Clinic, at main campus Cleveland Clinic, in the first 6 months, we found 50 new patients that were lurking around. So if that's the state of affairs in downtown Cleveland, imagine in rural practices, etc. So AI is helping us a lot, or will help us a lot. AI, using point-of-care ultrasonography, helps detect almost 60% HCM cases 2 years earlier. The world is moving towards earlier diagnosis so that we can do earlier treatment, right? This is 290,000 standard echoes done at Yale University and Mount Sinai. So the world is rapidly moving towards earlier diagnosis using intelligent machines. Let's introduce Jordan, not Michael, just Jordan, a patient aged 62 years presenting for cardiology follow-up, intermittent palpitations, mild chest pressure, worsening dyspnea and exertion, right? This could be 200 million adults in the world with this. ECG performed, medical history has paroxysmal AFib, hypertension, dyslipidemia, all the other usual things. He is on metoprolol, DOAC, and atorvastatin, okay? This is his ECG. You don't need AI. If you need AI for this, God save us. Okay. This person has LVH with strain pattern. So as we suggested, let's proceed to TTE. Okay. It is important to know not all thick walls is HCM and not all HCM is thick walls. Differential diagnosis widens with age. The less hair you have on your head, the wider the differential. It could be hypertension, aortic stenosis, HCM, athlete's heart, amyloid, Fabry's. Younger patients have Pompe's and Danon's. So all these phenocopies you have to ascertain. The last thing you want to do is give mavacamten to an amyloid patient and vice versa. This is Jordan's ECG. At rest, there's basal septal hypertrophy. With Valsalva, Houston, we have a problem. Sam with outflow tract flow turbulence and posteriorly directed jet of MR. 2 centimeter basal septal thickness, moderate severe SAM, posteriorly directed MR, 62% EF. Valsalva gradient is 75 millimeters of mercury. Hallelujah, Jordan is diagnosed with obstructive HCM. That brings Dr. Owens to the clinic. It takes a lot of effort to bring Dr. Owens to the clinic, but Jordan, she'll be there for him.
I'm here. So we're going to jump into long-term evidence, real-world data, and updated guidelines, looking at CMIs. So prior to 2023, We were using therapies based on very limited data. Limited evidence in terms of lack of randomized controlled trials, often observational, single-center, expert opinion data. And that started with the beta blockers in the 1960s, moved to the calcium blockers into the 1970s, and eventually the addition of disopyramide. None of these medicines were developed to target the underlying pathophysiology of what we see in HCM. They were drugs that were developed for something else, but were repurposed because of their effects to see if they could improve diastole, to reduce contractility, and see if they could really improve symptoms in obstructive HCM. It's really not until the CMIs were developed that we had the first targeted therapy for patients with HCM. And we saw that the first CMI, mavacamten, was approved in 2022 for the use in obstructive symptomatic HCM, incorporated into the ESC guidelines in 2023 and into the American guidelines in 2024. These are small molecules that are taken by mouth. They are importantly reversible, and they target the cardiac myosin and not skeletal muscle. And there are two drugs that are furthest along in their development. The first in class, as I mentioned, mavacamten, and the next in class, aficamten. Again, these are supported by prospective randomized controlled trials, which is a new era for us in hypertrophic cardiomyopathy. They act by modulating contractility at the level of the sarcomere, so the contractile unit of the heart, and they take a heart that's hyperdynamic at the level of the sarcomere, working too hard and poorly energy efficient, to one that is contracting more normally and relaxing more normally. Importantly, if you get too much of a drug effect with this mechanism of action, there's a risk of becoming hypocontractile. And fortunately, because they're reversible, if that occurs, you simply have to pull back on the dose, temporarily hold in the case of mavacamten, and down titrate in the case of aficamten to modulate that effect. So similarly to how cardiologists use positive inotropic agents to modulate contractility up, this is the use of a negative inotropic agent to modulate contractility down. This opens the paradigm shift that hypercontractile can be bad. High EF can be just as bad as a low EF, and really what you're targeting is that sweet spot in the middle. So what have we learned about cardiac myosin inhibitors? This is data presented on obstructive HCM. We had the first pivotal phase 3 trial, the EXPLORER trial, that was looking at mavacamten versus placebo. Now, that placebo group was on background standard of care medications, which are a mix of beta blockers, calcium blockers. Disopyramide patients were excluded from that first pivotal trial. Those patients were then rolled into the MAVA-LTE open label extension trial, and you can see that that trial is ongoing. The next phase 3 trial for mavacamten was the VALOR trial, and we'll present long-term data from both MAVA-LTE and VALOR today. The VALOR patients were sicker. All of them were under active consideration for invasive septal reduction therapy. So they were being considered and they were candidates for either septal myectomy or alcohol ablation. These patients were also on much more background medical therapy, combination of beta blocker and calcium blocker, beta blocker, calcium blocker alone, and a significant proportion, around 20%, also on disopyramide. So really maximally medically treated, but remain symptomatic and obstructed. The next series of trials that I have listed here are for aficamten, the next in class cardiac myosin inhibitor. Starting with the pivotal SEQUOIA trial, phase 3, this was aficamten versus placebo, where the placebo group was on background standard of care therapy, beta blockers, calcium blockers, some on disopyramide. And finally, the newest trial for aficamten, which is the MAPLE-HCM trial. This read out very recently in Madrid at the ESC conference. And for the first time, we saw aficamten CMI versus first-line standard of care metoprolol, both as monotherapy. So we'll get to those results. Patients from the aficamten program have rolled into FOREST-HCM. That is the open-label long-term extension. Start with the MAVA-LTE data. This is, again, patients from EXPLORER, obstructive HCM, rolled into long-term extension. What's important to note here is we now have data out to 180 weeks of treatment, so 3+ years on mavacamten. And what we've seen is sustained and impressive reductions in LVOT gradients, both resting and Valsalva, with Valsalva gradient reduction in the aggregate group reaching more than 50 millimeters of mercury. We've seen sustained reductions in NT-proBNP and sustained improvements in quality of life scores. It's sustained improvement in NYHA class with nearly 80% improving by greater than or equal to 1 functional class. Now, we've also seen, as expected by mechanism of action, a decrease in LVEF in that contractility that's being modulated. But in aggregate, we have patients with an EF still in the normal range of 64%. We're taking people that are hyperdynamic and putting them into the normal range. This is important because it tells us that people can take this drug potentially lifelong with durable benefit and also durable safety, which is important. So what's new in terms of mavacamten data in obstructive HCM? We have that there were EXPLORER results from MAVA-LTE that I will be presenting, and this will be the first time that we're looking at effects of the drug in long-term fashion based on duration of HCM diagnosis. So this will look at patients who were diagnosed greater than 10 years ago, 5 to 10 years ago, 0 to 2.5 years ago. Really to get at the question is, does it matter when you start this drug? Will you be able to see the same efficacy and safety? And we'll present that data on Monday. So looking at favorable cardiac remodeling, beyond the hemodynamic effects of gradient reduction, which is important for symptoms, what are we seeing with this class of medication in terms of long-term cardiac remodeling and how this might relate long-term to a change in the natural history of disease, which is ultimately what we're looking for with a medication? Can this drug change the course, the natural course of disease in this patient, and ultimately allow them to avoid the complications that we know can occur with HCM, which are AFib, heart failure, stroke, ventricular arrhythmia? So what do we know about remodeling? And here's data from the MRI sub-study. So it's a relatively small number of patients, but still a good number who got MRIs. And this is based from both the US and the Asian studies of mavacamten. And you can see what we've seen is pretty remarkable changes in indexes that represent adverse remodeling in this disease. So improvement in left ventricular mass index, improvement in left atrial volume index, improvement in maximal wall thickness. Now, again, that's the hallmark of this disease is pathologic hypertrophy. So if we are seeing regression of that hypertrophy in a compensated heart, a heart that has a low NT-proBNP, a patient who's asymptomatic, that's favorable remodeling. And again, the LVEF in this group by MRI was down by about 4%. This is data from VALOR. Again, VALOR were those sicker patients who were on the cusp of getting an invasive therapy like myectomy or alcohol ablation. And we now have data out to 128 weeks on these patients. And you can see here that only 7 underwent SRT. That's pretty remarkable. When you take a patient who is class 3, over 90% of these patients were class 3 at baseline. They were actively considered for invasive therapy, and they were able to not need that invasive therapy out to at least 128 weeks. And you can see on the right-sided panel, improvement in KCCQ score, quality of life, improvement in NT-proBNP, and troponin. So what else do we know about structural changes, remodeling from VALOR? We saw very similar changes to what we saw in EXPLORER. So even in that sicker group of patients, we're seeing improved left atrial volume index. Once you relieve that obstruction, the left atrium starts to shrink down. It's under less pressure. We saw that longitudinal strain improved. So that's an interesting finding. Even though you're modulating contractility by our somewhat blunt instrument of an LVEF, even though my friend is a cardiac imager, I can poke a little fun at it. It's still a pretty blunt instrument. We saw that strain improved, and that's important. We did also look at subgroups that are of interest. Patients who have a history of AFib. This is quite common in our patients with HCM, up to 30%. And that is a high percentage, particularly in patients with obstruction, that they're likely to get AFib in their lifetime. And we also looked at the subgroup who had an LVEF less than 50%, so those who transiently dropped to less than 50. And we saw no worsening of their cardiac structure. So what about safety data that's longer term? For this study, presented an abstract form last year, presented it. We looked at pooled safety data. So this is pooling all of the patients on mavacamten across 5 trials from the obstructive group. And we looked at AEs of clinical interest. That includes atrial fibrillation, EF being decreased, and heart failure. And what we saw over time, out now to year 5, is a decreased incidence of those AEs of clinical interest. This is, again, reassuring that we're not seeing more AFib, we're not seeing more heart failure over time. Those complications of this disease are going down. I just presented this morning impact of mavacamten on hospitalization. So again, we're going to move beyond the mechanical hemodynamic benefits, beyond the structural remodeling, and really start to look at outcomes in our patients that we see every day. This is real world. These are patients that were prescribed mavacamten as part of the commercial program. And we looked at their rates of hospitalization, rates of ER visits, rates of outpatient visits. And we saw over, on average, a relatively short follow-up of about 9 months, that hospitalizations were decreased by 86% for HCM related, 55% for cardiovascular related, and 37% for all cause. We also saw a decrease in ER visits, about 47% for HCM related, 45% for HCM symptom related. So that means presentation to the ER for chest pain, shortness of breath, palpitation, syncope. Those went down. And 36% for CV related. There was overall no change in outpatient visits, but there was, in that group of outpatient visits, a slight uptick in the number of stable routine outpatient visits. And why was that? Most likely because we're bringing patients in to do safety echoes as part of routine monitoring for the REMS program. So there is an uptick there, but overall, symptom-related outpatient visits were down. So now let's switch gears. We're going to talk about the next-in-class CMI. This is aficamten. Not yet FDA approved, but we expect a PDUFA date in December for this drug. So this is the open label long-term extension. These are patients who came from a parent clinical trial on aficamten and have now rolled into open label. This is 48-week efficacy data in patients with obstructive HCM. This is from Redwood and from SEQUOIA. And what you're seeing are very similar effects on hemodynamics. These drugs work very well to bring down gradients. So resting gradients down by 40, Valsalva gradients down by over 50, NT-proBNP down by over 60%. Again, a small change in left ventricular ejection fraction, in aggregate about 5%. Keep in mind that there's individuals within there that may have a more significant drop. And that's why we do the safety echo. If you get someone who drops below 50, you want to know that so you can adjust the drug accordingly. And over 80% improved by one NYHA class. So what's new from the FOREST data here at this meeting? Well, just yesterday at our HCMS meeting, we had a presentation on PROs from the FOREST data. So these are all the patient-reported outcomes, and we saw sustained improvements in patient-reported outcomes. So this is important as we translate short-term clinical trial data into longer-term studies and eventually to the real world. Is this a sustainable path for our patients who wish to stay on pharmacologic therapy and not undergo invasive therapy? So far, the answer is yes. And then we also have remodeling data from FOREST-HCM, and that was presented today by Dr. Hegde. Unfortunately, I didn't see the live presentation, but it showed, again, improvements in those markers of cardiac structure and function that tell us that the drug has a continued benefit over time. So this is brand new data from MAPLE-HCM. Again, this was presented at ESC just a couple of months ago. And this is groundbreaking because it's the first time we're seeing a CMI, in this case aficamten, head-to-head against what we currently think of in the guidelines as first-line therapy, metoprolol, a beta blocker. So this was a trial design that allowed patients who were on standard of care to have a washout. So we think of that in terms of what might have been the biases brought in. The physician has to think that that patient was stable to undergo a washout. And then there were also patients who were naive to therapy, fewer of them, but there were some who were also naive to any therapy and had a recent diagnosis or had a longer-term diagnosis. Both were included. And they were randomized aficamten versus metoprolol for a period of 24 weeks in this trial. The primary endpoint was CPET with a host of the usual secondary endpoints. So here's the primary endpoint. This is peak oxygen uptake on the left-handed side. And many of you may not routinely perform CPETs at your institution or be looking at VO2s in HCM patients frequently, but it is rare to see a crossing of the lines. So here you see that aficamten group went up by about 1 mg per kg per minute, and the metoprolol group went down by just over 1 mg per kg per minute. So that would suggest to you that in this trial, based on the algorithm and the dosing titration that was used, the patients in metoprolol got worse, and the ones on aficamten got better. And that resulted in a least squared mean difference of 2.3 mils per kg per minute, which was highly statistically significant. When we looked at metoprolol versus aficamten with regard to NYHA functional class, NT-proBNP in the middle, and LVOT gradients, you can see that aficamten was superior to metoprolol in all three of those endpoints. And again, it's worth noting that the gradient in the metoprolol group, there on the far right, really didn't move at all. And that's something that gave us pause when we looked at it, because at least in our heads, we thought there were some people that responded to metoprolol in clinic and that their gradients went down. And so something to think about. And I'm not sure I have an answer. If we have time at the end, we can think about what might have caused that. And we saw the NT-proBNP go up in the metoprolol group. So perhaps worse with metoprolol. In terms of adverse events, side effect profile in afi versus metoprolol, fairly similar, except that there were more AEs that led to dose reduction in the beta blocker group. And these were patients who were titrated on metoprolol every 2 weeks up to a maximum dose of 200 milligrams of metoprolol, so a pretty high dose of metoprolol. And so there were hold parameters for hypotension, for bradycardia, and several of the patients there met those criteria and led to dose reduction. Importantly, there was only one patient in the aficamten group that had an LVEF less than 50%, and nobody in the metoprolol group. So sub-studies from SEQUOIA, it's important to look at this real-world data and look at the comorbidities of these patients to see how it might translate into the real world, where we know the patients aren't as clean as those that go into clinical trials. We have a lot of hypertension, a lot of obesity, a lot of other comorbid factors, CAD that's non-obstructive. And it's good to see that even with those comorbidities, this drug class is effective. So what do we know about mavacamten monotherapy? We don't have a head-to-head trial like we have with aficamten, but we have some data that again was presented by Professor Olivoto at the ESC conference. This was from looking at the pooled trials of mavacamten and just pulling out that group that happened to be on no background therapy. So they were essentially getting mavacamten monotherapy or placebo monotherapy, no beta blocker. And again, it's a small number of patients, so this is hypothesis generating, but we did see that gradients came down, that improvement in NYHA improved, and so similar effects to what we saw in MAPLE. So here at AHA, we're also going to see two additional studies. One is mavacamten monotherapy in real-world patients, so getting a sense of what that looks like. And what it often looks like in clinic is that our patients want to come off their beta blocker. Once they're stable on mavacamten, they're feeling great, and they say, can I get rid of this medicine, the one that might make me fatigued or make me have erectile dysfunction or some, nightmares or whatever the problem is. They may want to just come off, or they say, do I need this medicine? I feel great now, and can I come off of one medicine? So look for that data, monotherapy from COLLIGO-HCM, which is a real-world analysis of centers that are participating and prescribing mavacamten. And also looking at symptomatic and hemodynamic improvements from MARVEL-HCM. Again, this is a real-world study looking at monotherapy in patients on mavacamten.
Let's talk about personalized therapies. How do we play with all these ideas and these novel therapies in the clinic? Tailored treatment strategies and shared decision making. So, with all these data that Dr. Owens walked us through, there's a lot of stuff that came out, and the guidelines quickly recognized all this. So 2024, the guidelines said, try the first-line therapy if symptoms persist, use myosin inhibitor or DISO or septal reduction therapy. Who in the right mind would give DISO right now in 2024? Not me. No mother-in-law joke here, okay? But this is where we are. So let's talk about how we do mavacamten. Especially, this was approved in April 2022. I'm losing track of time now. Under the REMS program, Risk Evaluation Mitigation Strategy. Because why? Because the federal agencies wanted some adult supervision. They wanted to make sure patients were safe. These are cardiac myosin inhibitors. They're going to inhibit the cardiac myosin. So we want to make sure the EF is not an issue. Okay? So reversible, but still EF reduction is an issue. Drug-drug interaction. These drugs excrete through cytochrome P450 system. And we have to understand that. And there was a learning curve. And more importantly, all of us need to be on the same page. The patient, the NPs, the physicians, the pharmacists, the nurses, everybody, right? And we needed training, So yesterday I made a comment. This made all of us into MBAs, fast-tracked into operationalizing and logistic, whatever. So, but behind every learning situation lies an opportunity, right? This helped us create the world's largest prospectively collected echo database in obstructive HCM. This is the data we presented last year at AHA of the first 22 months of the REMS program in more than 6,000 patients. We found it is safe in the wild. Okay, 4% LVEF, less than 50%. the combination of heart failure hospitalization and in the setting of EF less than 50% was 0.2%. That's the one that is absolutely important. At that time, 52,000 drug-drug interactions happened, and, non-story. So we developed the processes that basically kept us out of trouble. And we were able to prove it using this REMS data. This morning, many of you saw me run from one session to the other, but I did manage to make it on time to present the 34-month data on almost 12,000 patients as part of continuing REMS program monitoring. 147,000 drug-drug interaction checklists completed. Again, no story. Okay? The system for which it was set up is working. What did we find? 7,462 patients initiated at 5 milligrams per day and treated for more than 6 months. Majority of the patients remained on 5 or 10 milligram dose. The number of patients, in fact, 1,619 patients, the response was so good that we had to down titrate. Okay. Why poke the bear, right? We treat to maximum efficacy. Now, what did we find? There are 2 graphs on the right. The top one is for the entire 10,986 patients. Every patient got different exposure, right? So this analysis is exposure-adjusted incidence rate. So EF reduction in the total population was 5.59. EAIR, the combination of EF reduction 50% and heart failure hospitalization, 0.35. So relatively safe, not very safe. Bottom group of graphs is 2,078 patients who had, they were followed up for a longer period of time, okay, with a longer amount of dispense. I'm getting used to that. EAIR is 3.94, suggesting Dr. Owen's data from last year, the longer you stay on it, the less the incidence of side effects, right? So safe in the real world, safe in the real world. It is obviously contraindicated for use in CYP450 inhibitors and inducers. So this is something you have to be aware of it. Certain drugs that may interact with these, you have to adjust their dose, stop them, all that happy stuff. In real life, at least in my practice where we work, we don't have too many what you call HIV type patients, but the most common drug is proton pump inhibitors. So omeprazole, you switch it to pantoprazole, right? If you are in a fungal heavy practice, then you may have to adjust the fluconazole. But it is important to recognize this, but it is also important to have your pharmacist as your best friend, right? They are a tremendous resource. So you can download the practice aid. This is important, right? The interprofessional workflow. This is, at the end of the day, a team sport. Involves physician, pharmacists, often the nurse practitioners, the pharmacists, assesses the DDIs, they counsel the patients. Somebody, part of the team, the nurse practitioner, pharmacist, enrolls the patient. There's prior authorization, discussion of costs. Then there's a setup for the echocardiography. In our program, what we have done is we have created a limited echo so that you're not spending an hour every time the patient comes for their echo. You need targeted EF gradients, Valsalva gradients. And we have created order sets with built-in reminders, etc. Then you have to review the images and or the report and make sure everything is okay. The important thing here is, unless the report is electronically entered on the REMS website, there is no other dispense, right? So this is a shared decision. The patient also needs to be responsible, just like us. This is a shared responsibility. What's some of the other real-world data? This is something we just presented a couple of months ago at ESC from Cleveland Clinic. Okay, we have a tertiary care center. Patients come from all over. These are the first 244 patients, at least 3 months. Okay, and you can see the patient population slightly older, slightly 82% on beta blockers. We have not stopped them. They're still taking some beta blocker doses. Everybody was initially 5 milligrams a day. At 12 weeks, the outcomes aligned with clinical trials. Okay, NYHA class, gradients, strain. More importantly, out of these 244 patients, one patient has undergone SRT. One. Okay. It makes me very popular with my surgical friends, but it is what it is. So what are some of the next steps for Jordan's treatment? Following remember Jordan with that LVOT gradient of 64 or what have you, during interprofessional team care conference, Jordan wants to be a candidate for CMI. You enroll him in the REMS program, prior authorization, everything goes well. 4 weeks, Valsalva gradient 38. 8 weeks, it drops to 33. At 12 weeks, patient is technically in the non-obstructive range with a preserved EF. Plan is continue current dose. So the FDA, about 6 months ago or so, they came up with guidance. Initially, when the REMS program was rolled out, you had to get echoes every 3 months once you reach steady state. Now it is every 6 months to get an echo. Thank you for joining us. This is the time. Now I think we have deliberately left time for Q&A. If you don't ask, we will ask you to ask.
Here's some questions. You got them ready to go. All right. The first is, what do you think is on the horizon for use of mavacamten monotherapy? What do you think? What's coming next?
So I think, the business of monotherapy is exactly that, the business of monotherapy, right? Beta blocker, metoprolol, tartrate, succinate, you go to Walmart. How much does it cost per month? $4 or something like that, right? So what's going to drive this monotherapy business, I think, is the market forces. Do you agree?
Yeah, absolutely. I mean, these are still expensive drugs, and they require an implementation process that's not required for something that's cheap and relatively easy as a beta blocker. So I do think that we will see monotherapy of CMIs, but I don't see beta blocker use going entirely away.
I mean, okay, so since we started the party with discussion of monotherapy, let me ask you a question. We've been in practice for a couple of years. You a lot longer than me. No, not joking. How many patients have you? And by the way, you are also a card-carrying heart failure doctor. Okay, I'm not. How many patients have you seen in your practice where in half a year, their BNP goes up by 41% just by being on beta blockers?
I have not seen that.
You're not seeing that,
No.
But we saw that in trials.
Yeah.
How do you explain that?
I think that was probably a function of the titration protocol that was used in the trial. We haven't seen that, nor have we seen declines in peak VO2 that are that abrupt in a disease that's a lifelong, generally speaking, more gradually progressive disease. Now, there are those patients that have severe obstruction and need something done relatively soon. It's rarely an emergency. But we haven't seen that. And so my guess is it may be a function of the up-titration of dose fairly quickly over a short period of time.
So, look, I mean, most of us, at least the way the practice has evolved is you start, if they are naive to first-line therapy, we start them on something. And, back in the day when we didn't have too many options, before we send them for septal reduction therapy, we would go up to from 25 to 50, 50 to 100, etc. Now, with the availability of a CMI, am I prone to go up to 100 to 100, 150? Probably not.
Probably not. Absolutely. I think
What do you do?
Yeah, you would stop after 50-ish.
Exactly.
Or early symptoms that they're not tolerating it, they're getting side effects, they're still obstructed, they're still symptomatic, and move on. But I think until we get beyond that issue of price and implementation hurdles, that there still will be use of beta blockers. Or there's a long enough study and time to show hard outcome benefit, survival benefit, for example, really hard cardiovascular outcomes that we get with other drugs, right? We get it in, DCM and HFrEF, and we say, I don't care how bad you feel, you're taking your Coreg because it's going to make you live longer, right? Until we get data on agents to say that they prolong survival or hard outcomes, I think that might change the game.
Yeah. Again, that's why I said the business of monotherapy is going to be driven by the business.
Yeah.
As business piece of it.
Okay, here's another question. What role impact does genetics play in HCM?
Genetics is a big player in HCM. This is probably one of the most studied genetic disorders in all of cardiovascular medicine. But genetics is not be all and all. Genetics, when most people talk about genetics, they're talking about monogenic disease. Do I have one mutation? Tell me that, and then I can go home and screen my kids, right? So what we are doing, based on current evidence, if you take 100 HCM patients that look HCM, Anjali Owens looks at them and says, you have HCM. Forget about me. Anjali says that. You have HCM, meaning you have HCM. And then you do genetic testing, about 40% are gene positive. The rest of them are not. And the data is emerging. Some of it could be polygenic. Some of them we still haven't figured out, etc. So there's more to the story than just genetics. Having said that, we published earlier in the year a sub-study, secondary analysis from VALOR, which showed that the effect of CMI, the favorable effects of CMI, were observed independent of genotype status. So the concept of CMI, application of CMI therapy should not be driven by genetics, at least based on the data that we have right now. Look, earlier today I presented data on gene therapy. That's a very different discussion, conversation for another day. But CMI therapy, this is how we are.
All right, I got a tough one here. We're nearing the end. I'm going to let you marinate on this one. Actually, let's do a softball first. We'll save the really hard one for the end. Do you ever titrate more rapidly or slower with mavacamten versus the trial? And I would say absolutely. Use your clinical judgment. When we design these clinical trials, they're designed to show efficacy as quickly as possible, as much safety as possible, but you've got to get to your trial endpoint. That is not often the real world. So in the real world, if you're dealing with someone who you feel by looking at their comorbidities, other features on their echo, history of response to other medicines, that they might be best to start with a slightly lower dose, that's fine. And what I learned early along in the real world experience is that perfect is sometimes the enemy of good. So if you have a patient who's class 1, they're feeling great, you happen to pop them on the treadmill, and their peak exercise gradient is 49, 51, there's no need to uptitrate that patient. We don't have any data yet to say that we need to be titrating to sort of maximally tolerated effect. Minimally effective gradient reduction, symptom improvement is really what we're aiming for at this point. So I don't feel the need to follow that type of, aggressive uptitration. If the patient's feeling well, their gradient started at 120 and now they're at 49.
Exactly. So I was about to use that example. You start at 120, you are symptomatic, now you are 49. Yes, the label says more than 30, go up or what have. No, but I wasn't able to climb a flight of stairs. Now I'm going up and down all the time. Yeah. Why poke the bear?
Yeah, absolutely. All right. And probably the last question here is we have a question about.
They say we can go
over a little. We got two more then. Non-obstructive HCM and CMIs.
All right. Non-obstructive. We are the two people. First and second authors are on stage. So non-obstructive is, so I'll start by saying, in the drug development program, it's human nature to go after what? The lowest hanging fruit. What's a low hanging fruit in hypertrophic cardiomyopathy? Obstructive piece, right? So that we have shown lots of data. Now, once you take out obstruction from there, bring to the realm of non-obstructive HCM, they still have symptoms. What are the symptoms coming from? Diastolic dysfunction, subendocardial ischemia, chronotropic incompetence, arrhythmias, etc. So you don't have the low-hanging fruit. Now you got to climb a little higher in the tree to get the apple, right? And more importantly, you don't have a marker to modulate, like a gradient. So what is the marker? Symptom improvement and or ejection fraction. So the pivotal trial, the phase 3 trial, Odyssey trial that was done, we ran that trial, which compared MAVA to placebo. And the question was, does it improve exercise capacity? Does it improve quality of life? Those were the primary endpoints, which the p-values were 0.06, 0.05, which means it did not meet statistical significance, and it did not meet the clinical criteria that we had established upfront of significance. That the p-value was 0.5, 0.06. But what we found in the sub-studies is biomarkers. The BNP troponin reduced by 50+%. So that part, the pathobiology, is behaving like what we saw in obstructive. It also resulted in reduction in mass and diastolic function and all that stuff. In fact, yesterday we showed, so there's something happening. Yesterday we showed some data. Anjali also showed the data on the, I'll let you speak to that, the peak VO2 and all the CPET sub-studies. And I showed that if you start off with an EF of 65% or more, or without a history of atrial tachyarrhythmias, the response is, it may reach statistical and clinical significance. And the EF reduction is, or the side effect profile is much better. CPET data. What did you think?
And I think really what we have to do with non-obstructive HCM is understand that it is a spectrum of diseases that are all being lumped together right now. With obstructive HCM, as we mentioned, you've got that biomarker of a gradient. So you know pretty much what those folks are going to look like. Within the non-obstructive group, you have patients who are still hyperdynamic, but you also have patients who are moving down the spectrum of contractility through progression of their disease, some of whom are no longer hyperdynamic and may be on that border of too far along, too sick to benefit from the mechanism of myosin inhibition. And I think right now we've put all 580 of those patients into one big trial. And so we might find that there are subgroups that respond better than others, and that's what we're investigating now. The other thing is that it may be really hard to see that dramatic of improvement in clinical markers, clinical endpoints, peak VO2, KCCQ, in the non-obstructive group, as opposed to the obstructor group, where you relieve that obstruction, you're getting benefit in terms of peak VO2. So what we looked at in the CPET sub-analysis was really beyond peak VO2, markers of sub-maximal exercise performance, which is where our patients live. Most of your day, you're doing sub-maximal type exertion. You're not going all the way to peak. And if we could have benefit in that realm of sub-maximal function, which we looked at looking at the ventilatory threshold, we saw that there were improvements, fairly notable improvements that were on the clinically significant, statistically significant side in an exploratory post-hoc analysis. But nonetheless, that may help to inform trial design when we're looking at the non-obstructive population, which is a different disease. And I think we have to recognize it as that, a more complex, heterogeneous disease, and tackle it in that way. And there may be other drugs that come with different mechanisms of action that can be used in conjunction, separately, or together. More of a paradigm that we see in DCM and HFrEF, where we look at all the different pathology. As Melinda alluded to, there's microvascular disease, there's energetic issues, there are other pathways that perhaps we target in combination to really tackle that non-obstructive group. But I do think the biologic signals were still there for benefit with myosin inhibition. Great.
Anything else?
I think that's it.
Thank you.
Thanks for joining us tonight.
Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported through an educational grant from Bristol Myers Squibb. To access all materials for this activity, visit peerview.com/MYA860.